speakers. So Dr. Sartaj is going to be talking on why monofocal IOL still holds its place, and debating on this issue of content against him is Dr. Himanshu Mehta, an extremely popular and allied surgeon, a medical director of the Vision Eye Center, Mumbai, and also President IRSI, who brought in major changes and energy to the IRSA platform during COVID times. And he would counter monofocals by saying that the enhanced multifocals have replaced monofocal IOLs. So we first take Sartaj for the 6 minutes, and then immediately he would be followed by Dr. Himanshu Mehta, and then the discussions would ensue. On to you, Sartaj.
Good afternoon. Thank you so much, ma'am, for this opportunity today. So today I will be speaking on supporting basically conventional monofocal IOLs and how they still hold their place in today's day and age, even with the introduction of newer generation monofocal IOLs, which claim to provide a greater range of vision. So we should start off by understanding, first of all, that there is no free lunch when it comes to the physics of optics. What that means is that with all these lenses, you are essentially sacrificing something from distance vision for the sake of intermediate vision. If we look at the defocus curves that have been published by various clinical studies, where we are basically comparing the IHANS, which is the most popular new generation monofocal IOL, versus its own counterpart, the Technis one, the ZC-BOO, which has been a gold standard for quite some time, we can see in all these defocus curves that the Technis one provided better distance visual acuity as compared to the IHANS across the board. We can appreciate that as we go towards intermediate vision, the IHANS did provide better intermediate vision in all of these defocus curves. So that says that at least you're getting good intermediate vision, even if you're sacrificing something, right? Well, if we look at the directions for use that come along with the IHANS IOL provided by Johnson & Johnson, if you look at this text over here in blue, and I'll blow this up, it actually says that clinically meaningful extension of depth of focus has not been demonstrated in clinical trials. They even go on to admit that extending the depth of focus negatively affects the quality of vision at far distances. So we have to remember that our cataract patients, they judge their results on the basis of distance visual outcomes on day one in our office, looking at that Snellen visual acuity chart. And if a patient is not satisfied with that distant visual acuity at that point, it can be quite problematic to satisfy that patient. We also have to remember that as of now, with these newer IOLs, the IHANS, there is no option for patients with corneal astigmatism in India. We do have the IHANS Toric 2 available in international markets, but it has not been introduced in our market as of yet. So we have to also accept that most patients would not notice that decrease in distance visual acuity. Sure, a very particular patient with a conventional monofocal IOL in one eye, and we were planning a new generation monofocal IOL in the other eye, they might notice. But yes, for most patients, they would not notice that. We will admit that. Also, as credit to these new generation monofocal IOLs, I will also accept that all the clinical studies that have been done have shown that there's no significant difference in contrast sensitivity or visual symptoms when comparing the newer generation monofocal IOLs to conventional monofocal IOLs. So where does it leave us? Basically, it leaves us in a position where we have to be very particular when we set expectations for our patients. We have to set realistic expectations. We have to market a lens which will give them better intermediate vision and will, maybe sacrifice something from distance visual acuity. But when the intermediate vision that we are promising with these lenses is so limited, it's only about half a diopter in near vision or intermediate vision, which most patients might not be happy with. So it is very crucial to set realistic expectations with these lenses. And when you're asking a patient to pay a premium over a conventional monofocal IOL, it's again very difficult to curtail expectations at the same time. So I feel that as long as this technology doesn't trickle down to lower, more cost-effective monofocal IOLs, the cost limitation alone will be the biggest barrier in patients and surgeons adopting these lenses for more and more patients. Thank you.
Thank you very much, Sartaj. That was a very crisp talk, and we